Welcome to this PSPA webinar, which is part of our Ask the Expert webinar series. Today, I'm joined by Dr. Susan O'Connell. Susan is a consultant clinical psychologist at the Queen Elizabeth University Hospital in Glasgow and a member of the Atypical Parkinson's multidisciplinary team. Our focus today is on questions asked about PSP and CBD and how these conditions can impact cognition and mental health. Hello, Dr. O'Connell. It's good to see you today.
Hi, thank you for asking me to be involved.
Yeah, brilliant. Oh, I'm really pleased you're here. Okay, if we can just start, it'd be really great if we can start the chat with an overview of your role and how the clinical psychologist can support somebody living with PSP and CBD and probably their carers as well.
Yeah, no, of course. So neuropsychology is a branch of clinical psychology which deals with the brain, the nervous system and psychological functioning. So clinical psychologists will work towards understanding how illnesses of the brain and nervous system affect memory, mood, and ability to function in daily life, but also looking to understand how emotions such as anxiety, stress, and low mood affect the brain and the nervous system as well. So it's kind of a focus of our role. Clinical psychologists in neurology have experience in the assessment and the psychological treatment of a wide variety of neurological illnesses. They will typically work closely with neurologists and other healthcare professionals, such as psychiatrists, nurses, physiotherapists, and family doctors. Often the neuropsychologist is able to take a kind of broad overview of patient issues, their care pathways, and work with the team to aim essentially to provide best care for the patient and their families. Patients with PSP and CBS can experience changes to how they think and feel, whether this be a result of the condition or the challenges of adjustment to living with a condition like this. So patients and their families may benefit therefore from assessment and possible intervention from a mental health practitioner, and a member of the team that's caring for that patient might suggest an onward referral to their local neuropsychology service if that's available, or onwards to the mental health team. I think it's important to recognise the impact PSP and CBS can have, not only on the person who's living with the condition, but also their family and their friends and carers. Neuropsychological assessment often involves input from the families and friends, and they can attend for joint sessions, which can be really helpful. But it's also important, I think, to give the opportunity for families and carers to have separate time to also address their own needs out with those appointments. So we can kind of work to link people in with our local carer services, or if required or if appropriate, we might be kind of recommending that the kind of family or the carer access their own GP to look at more specialised or individual support for them.
Brilliant. That's great. Thank you. That's a really good overview. I think often, as you and I have briefly discussed before, it's an area that doesn't get a huge amount of exposure, shall we say, in discussing PSP and CBS. So that's another good reason that you're here. Thank you.
You're very
Right. We'll start with our first question. They come as questions, they're discussions, sort of how you want to go about answering them. So the first one we are interested in hearing an answer to is if you could talk a little bit about the treatment of depression in PSP and any maybe adaptations or useful approaches that you might consider using.
Okay. No, of course. So although the question specifically says PSP, I suppose I'll kind of generalise this out a little bit, because I think a lot of the things maybe to kind of answer for this question would also be relevant for cortical basal syndrome or other kind of more atypical movement disorders as well. So there is some evidence for the use of psychological interventions that are grounded in more cognitive, behavioural or acceptance and commitment-based principles. I think often is the case, more research is always beneficial, to kind of build our confidence and developing that evidence base. But in clinical practice, typically what I would say more often than not, an integrated approach using different styles of therapeutic interventions are adopted by clinicians, and what sort of style of intervention or what therapeutic approach you use will be guided by the kind of initial wider assessment that you'd undertake with the patient and their families, and the formulation that you develop from that. I think it's important in therapy that we don't underestimate the impact of the patient experience, and I think therefore kind of validating what can and cannot be changed is important, and having that conversation at the beginning of any therapeutic intervention is helpful, just to set kind of clear expectations from both parties involved in that therapeutic relationship. Depression is often present in individuals, I'd say, in a more general sense, where there's a great sense of loss. And this can be a loss of health, relationships, opportunities, self-identity, or a loss of control over where you feel your life is at that point in time. And a diagnosis of PSP or CBS can lead to this very experience. And we often hear patients kind of talk about struggling to kind of find their sense of self, struggling to find a sense of meaning and purpose in life with this diagnosis. So I think taking time to explore the different roles and responsibilities a person holds and understanding the perceived way that these have changed is a really helpful starting point for any therapeutic intervention that you may deliver or engage in with a person. And I think that kind of gives permission to kind of step away from the diagnosis per se and kind of focus on who that person is in a kind of holistic way and all the different parts of life they have, not just the condition that they're now living with, because sometimes that can feel very kind of overwhelming and sort of feels like it can take over all aspects of life. So that's quite a nice approach I like to take to start with patients. We might often adopt what we call a values-based approach, and that's really can be helpful to look at the things that remain important to that person. So although they have been given a diagnosis of maybe PSP or CBS, that doesn't mean who they are as a person, their values, what's important to them is all of a sudden changed or no longer is meaningful for them. So a values-based approach allows us to identify that again and then help the person to navigate through life to engage with what's important to them as best they can. So I think that's a kind of more general overview of what the goals may be, I suppose, and kind of interventions for depression. I think in terms of engaging in therapy, I think it's important to hold in mind that often with these conditions, patients will have co-occurring cognitive difficulties as well. So there's some adaptations and things to consider, I suppose, with that in mind. So maybe thinking about using visual materials and handouts that hold key information only to support therapy. Maybe having therapy sessions that are shorter to manage any fatigue, which often is common within these conditions, can also be difficult for patients to sustain attention for a length of time. So having shorter appointments can be really helpful. Maybe consider the time of day that you have appointments with patients. You need to be flexible and adaptable. Some patients may feel better in the morning or the afternoon. And we want engagement with therapy to feel as accessible as possible. And it may be necessary also to consider kind of communication aids as well, especially if bulbar symptoms are present. So, asking the patient what's their preference for how you wish to communicate with them, sort of take their lead on that can be really helpful. What I would say when it comes to kind of mental health and kind of movement disorders in a more general sense, part of your initial assessment might be that you find that someone isn't ready for a psychological intervention, or this may not be the most helpful first step to engage somebody in a more structured therapeutic approach. So we often think about mental health interventions in terms of a stepped model. So you'd maybe map on a suitable level of intervention for the patient's needs at that time. So it's always helpful to consider what may be lower intensity interventions that you could perhaps access for that patient. For example, maybe providing psychological first aid, a term that we tend to use. And that doesn't need to be delivered by a clinical psychologist or a kind of trained mental health practitioner, like a CBT therapist. This can really be delivered by anybody who's involved in someone's care. And this would really involve ensuring things like basic needs are being met. So for example, is the patient sleeping well? Are they eating well? Connecting people with social supports, or listening to the experiences. Sometimes just active listening can be helpful as well, while gently encouraging maybe just building some self-care into someone's routine and day to day. And these are things that we all can do, as professionals in working with patients and their families. Another possibility may be accessing computerized modules to support people who may have mild to moderate symptoms of depression or anxiety. And this can be accessed through the GP, where the GP can make referrals on for that person. And I think kind of lower tiered or kind of low intensity interventions, sort of a bonus can be promoting self-management, I think, of kind of mental health, which can in turn enhance that person's feeling of control as well, which can be quite nice. And for some people, these lower intensity interventions may be enough to manage some of the mood difficulties that you might be identifying with families or patients you're supporting. But for others, this won't be enough, and they may need something more structured and a more kind of longer, more intense intervention on a one-to-one basis. So it's really kind of assessing what the needs of that patient is at that time, and then mapping on to a breadth of different interventions for them. I think as well, it's important to recognise that depression can also be a non-motor symptom of kind of Parkinsonian conditions. And therefore, medication may be helpful. There may be a role for medication. Us as psychologists would not prescribe medication or make recommendations around this, but it may be something with a conversation with the GP or the neurologist, that might be something they could become involved in to give some advice and guidance on that as well. The other thing I always hold in mind when it comes to kind of assessment of kind of depressive symptoms or mental health for patients is I always try and think, okay, well, what else may be going on here as well? Is it just what it seems? And hold a couple of different things in mind. So, for example, it can be important, I think, to differentiate between depression and what we would call organic apathy. The latter often is common within these conditions. So while somebody with depression can feel apathetic, they are separate conditions, and it can just be helpful to hold in mind that you've maybe considered that. So depression is a psychological condition, associated with feelings of sadness, hopelessness, loss of motivation and interest, whereas apathy is often a symptom of a medical illness like a Parkinsonian condition. A person with apathy may also show a loss of interest and engagement in things, but typically it's not associated with overt kind of emotional distress. You could be seeing more depressive symptoms. There are apathy rating scales you can use in your assessment to help tease this out. And I think differentiating between the two can be helpful to then educate the family and friends supporting the patient to understand the behaviour and the changes that they're seeing. And another thing, just from kind of experience in clinic as well, sometimes you find that there's maybe occasions where the family and friends report more concerns about mood than the patient perhaps reports themselves. So there's maybe a bit of a conversation around exploring, well, where's that coming from, and what's kind of driving that concern from the family and friends, and thinking, is it maybe apathy actually they're picking up, and we can kind of help educate on that. But sometimes I think family and friends can maybe interpret other signs of Parkinsonian symptoms, like maybe the fixed expression, kind of poor eye contact, reduced communication, maybe signs of depression, where actually maybe we can educate and help them understand what this might be. And also thinking, reduced communication can also be a loss of confidence in speech, and not always to do with kind of depressive symptoms or depressive episodes. So I think when it comes to intervention for depression with these conditions, there are therapeutic interventions we can offer, but I suppose it was just taking the opportunity to broaden it out a little bit, to say, there's other interventions we can consider that are lower intensity, and also the role of the kind of wider assessment is to tease out what else might be going on here. And it may well be depression, but there could be other things we need to hold in mind as well.
Brilliant. That's a great answer.
Is that okay?
Oh, it's absolutely brilliant. Really comprehensive. Great. I love it. Great. Okay. So this is a question we received recently at one of our study days from a health and social care professional. They're saying they'd be more interested in knowing more about the interaction between impulsivity, poor insight, and mental capacity, especially in relation to the right to make bad decisions versus insight causing a loss of the capacity to make decisions, maybe difference between perspective and experience. I wonder if you could give us a little bit of information about that.
So that's a tricky question, a really good question. So, okay, so trying to kind of think the best way maybe to answer that, so it's a helpful answer. So I think maybe in the first instance, it might be helpful to think about each of these things independently. Mm-hmm. And I think as well to consider that there's not just one level of impulsivity or poor insight, and I tend to think of them existing on a spectrum. So what I might do is just take each one in turn and talk a little bit about it, and then hopefully pull it together as we go forward. So impulsivity is a tendency to act without thinking, essentially, and it's classed as a sign of executive impairment. And executive difficulties are often seen within conditions like PSP and CBS. So we know that could be there and it can be present. And it can be the case that impulsivity can affect someone's ability to sort of process fully all information at hand. to allow them into an informed choice that that kind of speeds just, you know, the rapidity of the reaction to things, that kind of stimulus in front of them can mean they don't always have time in that cognitive process to think about all relevant information. And it might lead to somebody, you know, acting or making decisions that they would not normally do. Poor insight, if we think about that just separately for a minute as well, I think it is more about a person's difficulty understanding or lack of awareness about their own difficulties, secondary to maybe cognitive, behavioural or emotional change. And poor insight might affect the person's ability to properly risk assess a situation because they don't have that full awareness or understanding of these things, maybe not recognising limitations to their own ability or all the factors they need to consider to ensure they remain safe. So I wonder whether maybe giving an example of what this might look like, the differences could be helpful, just to tease it out. So maybe, you know, if you imagine a patient on an acute ward with a falls risk, and let's think about what this might look like for an impulsive patient. So maybe a person who's rather impulsive may have the thought of they want to walk to the bathroom independently when that's not the advice in the ward because of their falls risk. And that person may have the thought of walking to the bathroom, instantly try to stand up as soon as the thought comes into their heads, regardless of the risks that come with that. Another patient in a similar situation with being a falls risk with poor insight may have the same thought to walk to the bathroom and make the decision to do so, but it's based on a lack of understanding of what the risks are, and the decision to do this is kind of essentially based on sort of incomplete information. So it's not they have time to think about it, they're making a decision, but they just don't have all the information accessible to them because the insight's not there to understand what the limitations of the risks are. So I think both impulsivity and poor insight in this example of somebody who's maybe a falls risk independently mobilising in the ward may indeed have an impact on their decision to make, their ability to make decisions. And it depends on where they are on a spectrum. So it may be for these patients, it's possible to implement strategies or to put some scaffolding in place to minimise the impact impulsivity or poor insight would have for that person, and we could keep them safe and we can help them to make those decisions in a better way. But there may be some patients where, depending on where they are on the spectrum, those scaffoldings and strategies would not be enough to safeguard them and keep them safe. So you have to, I think it's really a complex interplay of different factors that leads to someone lacking capacity. And you have to be able to kind of think about a number of different things at the one time, really. And I suppose what we would do in that sort of situation is to understand this more, we would always complete what we would call a capacity assessment. And that would inform us an understanding that person's ability to make decisions for themselves, even if they're perceived to be bad decisions. And capacity assessments are essentially determining whether someone is able to use and understand information to make a decision and then communicate or action that decision. And if a patient is interpreted as making a bad decision, we need to be really careful not to assume that that means they lack capacity. Because it also raises a question of how do we define what's a bad decision? And we need to be mindful, I think, as professionals involved in these assessments, of the biases that we might bring into that, that dynamic as well. So it's quite a complex question. And I think that the capacity assessment is complex, and it's such that one must in detail be able to demonstrate that the person has understood the question being asked of them. They can show awareness of all the risks associated with this, what support or help may be required. And if they're choosing not to accept support and choosing not to accept recommendations, they need to be able to display they fully understand the consequences of this. And I think we as professionals involved in these assessments, we need to be able to evidence that we've put in place the necessary scaffolding to facilitate someone's ability to understand, retain and communicate their decision based on the information presented to them. So there's a definite role for us here to make sure that we're facilitating that. And if the person is viewed to have capacity, then it is indeed their right to make that decision, even if it's not one that we agree with. But I think we have to go through a very rigorous assessment process first to allow us to reach that conclusion, and it shouldn't be done quickly. Legally, there is no one blanket capacity assessment, just as much there is no blanket loss of capacity. So we often get asked questions of, well, does this person have capacity? But capacity for what? You know, what particular question are we being asked to assess that capacity for? And a capacity assessment should really be carried out for each decision that person is being asked to make. So capacity assessments, they do take time. The MDT should contribute. It should be a kind of, we should be accessing information from lots of different parties involved. And the consistency and response over different time points should be measured. And I think that's a legal requirement for capacity assessments, that we're looking for consistency in answers over time as well. So I think in terms of the question, it's a very interesting question. We've all had experiences where maybe we haven't agreed with decisions patients are making, or we feel things aren't safe. But if we stick to the principles of capacity assessments, and we're always kind of asking ourselves, have we assessed this properly? Who's been involved in the capacity assessment? Thinking of impulsivity and insight existing on a spectrum. Do we have scaffolding in place that's going to facilitate someone to make decisions? Because it's not likely we decide, or we come down and say someone doesn't have capacity. We don't want that for people. So I think it's a complex interplay of many different things, and this is how I would go about thinking about something like that, and really emphasising the importance of a really good capacity assessment.
Brilliant. That's again, great answer. It's something that comes up for us on the helpline a lot. People will contact us and ask about capacity, and we always say, well, to have capacity for one thing doesn't mean you have capacity for another thing. Yeah. But obviously we're always encouraging people to come back to people like yourself and get a proper assessment. So that's a really good answer. Thank you. Excellent.
And I think what I would say, so that I didn't kind of mention there, would be, the role of a cognitive assessment can be really helpful here as well. To try and tease these things out and look at someone's executive functioning and what reserve is there to kind of help scaffold and make decisions. And often the role neuropsychology kind of has in terms of capacity assessment is contributing the cognitive assessment to that discussion as well. So I think, like we said, it should be a kind of team approach and team decision, and assessments from lots of different parties, speech and language, yourself, physios, are all really, really relevant and important.
Excellent. Thank you. Brilliant. Great. Okay. So we've got a list of questions, haven't we? But I'm going to jump over because you've just mentioned cognitive screening. So I think it's most probably appropriate to put that question in now, if that's okay with you.
Yeah, that's fine.
Okay, so somebody's asked whether you use a specific cognitive screening tool that you recommend, such as the MOCA, or a more detailed assessment that they could refer people on for. So this is I think it's a Parkinson's nurse who asked us this question. I wonder whether you could suggest that. I know in MND that they use it. Is it an ECAS, which is disease specific? I'm not aware there is anything disease specific for PSP and CBS.
I'm not aware of anything specific either. The MOCA would be the screening tool that I would tend to use with patients who have Parkinsonian conditions. There are a few validation papers looking at its use within a kind of Parkinsonian population and support its use. And often in studies, research studies that are looking at cognition and kind of broader kind of atypical movement disorders, often the MOCA is one of the screens they use in research studies. So that's the kind of screening tool we tend to adopt within our service to use. What I would I suppose is an opportunity just to raise awareness that now to use the MOCA, you must complete online training to use the MOCA. There are certain criteria set out on their website. You can find that set out criteria for people who would already be competent to use the MOCA without necessarily having to do the additional training. So it's always helpful just to go on the website for the MOCA, have a look at what the competencies are for administering the MOCA, and there's an online, a kind of accessible online sort of brief training module that you can undertake if you don't meet that criteria. So that is something additional now to the MOCA that I don't think used to be there before, but is now in place. So just within your own practice, maybe just hold that in mind if you're using the MOCA. Do you meet the kind of competencies to administer it, and the online training's there if you think that would be helpful for you to do. Just thinking about cognitive screening in general, I think it's always helpful before you screen anyone to kind of ask yourself the question, why are you screening the patient? What's the question you want to answer by doing so? And having that clear clinical question there before you begin. Asking yourself, what will you do with the results, and how will that inform care? And it's also important, I think, when we're using cognitive screens to have what we call a clinical governance structure in place. So if you screen someone and they're coming out suggestive of cognitive impairment, having a clear pathway to know, well, where do you go with that? So I think the question that was asked, they said if they needed more detailed assessments, they would refer on. So it's just, where would you refer on to for your own individual area and your own services? So yeah, do you have a clear pathway for that? And is there a cognitive assessment specialist who'd be available to offer supervision or consultation if you are regularly doing cognitive screens? And a colleague of mine quite often uses the phrase, don't screen unless you can intervene. So it's kind of having a clear pathway in mind for your service of, should concerns be raised from screening somebody using a cognitive tool like the MOCA, where would you go with it next? So having a very clear clinical rationale for doing it in the first place, and then ensuring that you have a good pathway in place for your service for where to go next should you have concerns.
Brilliant.
And I think as well, another thing I would think of, just screening or cognitive testing in general, is just think about, are there any other factors at play that could influence someone's score? For example, low mood, anxiety, fatigue, or pain. And it may be actually a decision would be that you have to address these things first before you'd go on to look at cognitive screening, because these are factors that can have an impact on someone's cognitive functioning anyway, and could then influence their score on testing. And bearing in mind that any score we do get from screens and even more detailed cognitive assessment, yes, are very helpful, but it is only one piece of the puzzle. So always hold in mind that kind of holistic nature of your assessment, that your testing tools will be valuable, but think about the clinical presentation, the history, someone's functional ability, corroborative information from family and carers. They're also very important and allow you then to kind of accurately interpret the kind of any screener or cognitive testing that's carried out with someone. And that would be true for any cognitive screen used, whether it's ECAS or MOCA and Addenbrooke's. I suppose they're just things I would always hold in mind when it came to screening.
Excellent. Thank you. Great. Okay, so another question. The ladies asked, they've got a patient with CBD who's deteriorating pretty rapidly, and he's talking to his wife, and he's saying to his wife that he's considering committing suicide should he have to move into a nursing home. It's obviously distressing for both of them, and she feels it's a very real threat. How could they be supported with this?
Gosh, that's a difficult one, isn't it? And unfortunately, we do hear similar sort of examples quite a lot, don't we? It's a difficult one, and I don't think there's one definitive answer I can give of this is what to do to make that situation better. I suppose just from the little bit of information that was there with the question, so it's got my kind of interest going about it. I'd want to know more, and I think that's probably the thing I'd start with. I'd say, okay, I'd want to understand what about his condition has deteriorated more recently. Is it very likely that yes, a nursing home is indeed the next step in his care pathway, or is this an assumption or fear the patient holds? So I'd want to kind of get a bit of a check to see, well, what's the reality of the situation, and what indeed may be the next steps. I'd also want to kind of do some wider assessment to understand the patient's perspective. What are his anxieties, fears, or concerns about care moving to a nursing home? And might it be, to that conversation, we could identify anything we could maybe put in place or do to make that feel more tolerable? Some conversations I've had with patients, the kind of fears or anxieties they hold, when we give more information, we maybe do visits to the nursing home, we maybe get a liaison worker to come and meet and speak with the family, we can alleviate some of those concerns and fears that someone may hold about their care transferring into a nursing home. Not saying that would work with everybody, but I think it's just been, I think I'd first of all want to know, well, what's that person's concerns? What is it about that prospect that's made them feel that suicidality is now something that they're thinking about? I think some patients feel strongly they want their care to remain within the family. And I think this places significant pressure on carers to be able to kind of meet that need. So maybe addressing this separately as well, linking with carer services, having those kind of broader conversations about what is possible at home, what's not, why that might not be the case, and kind of linking into carer supports can be helpful as well from the wife's perspective. I think when a patient does disclose suicidality, I think it's really important to carry out a risk assessment. We need to consider whether you yourself as a professional supporting that family feel able to carry this out, or maybe it might be identifying who could be best placed to do this if you're concerned about risk for that patient. We need to be explicitly asking about suicide intent and plans, because we need to we need to accurately be able to kind of establish current levels of risk for that person. It may open up conversations about protective factors that we can build on as well, or we can, sometimes these conversations begin, patients might say, well, actually, no, we wouldn't do that to my family, or actually, no, there's more protective factors there than perhaps what they maybe identify initially. Depending on circumstances and presentation, I suppose you'd also want to make sure there's no mental illness at play that might have an impact on that person's capacity, which could then trigger maybe more kind of legal legislation to safeguard the patient as well, which maybe isn't the case with this particular example, but again, you'd always just want to make sure that you'd considered that. I think following any risk assessment, it'd be important to ensure that you're communicating that to the wider team supporting the patient as well, including involving a GP, involving any carers involved, any clinical nurse specialists, with the family who are supporting the patient as well, about, you know, what are you doing in response to that risk, and what any management plan would look like. Because I think that whilst these assessments are underway, managing risk at home would be advisable, and giving advice to the family of what they could do to kind of help safeguard the patient can be helpful as well. So, for example, maybe taking away access to medications, ensuring medications are being taken as well. Maybe considering that, you know, depending what the risk assessment might indicate, you might want to say, well, is it helpful for family to stay in closer proximity to this person in the meantime till risk assessments are put in place as well. Maybe agreeing on an escalation plan could be helpful, you know, so guidance to maybe contact the GP in working hours if things reach a crisis point, or presenting to A&E would be another thing we often advise patients to do. Maybe ensuring they have numbers for helpline services like Samaritans, Breathing Space, having it available so families feel they've got somewhere to go should things reach a crisis point at times they can't link into other services. I think that, you know, if a patient does have capacity and they're making an informed choice, unfortunately as professionals we can feel very limited to what we can do or what we can put in place with respecting patients' rights. So it is a very difficult, delicate balance. But I think my starting point would always be assessing risk, exploring the patient's perspective and understanding what's led to them feeling that way, and is there anything that we can do to make that feel more tolerable or mitigate some of that risk. I think would be maybe a few helpful, maybe some suggestions there that person can undertake to support that patient and their family. But there's not one thing I can say is going to kind of make that situation immediately better, but this is the sort of structure I'd be trying to kind of put in place.
Yeah, fantastic. I think that's some really good hints and tips there, isn't there? I think it's I know that working on the helpline, we don't hear this lots, but we do hear it, and it's always quite difficult for us to say, you know, to point somebody in the direction of where to go with that. But I mean, your answer is really helpful for us as well, because we can make some suggestions of what people should consider and where they should go with it. So it's great. Thank you very much. Okay, so our last question, you'll be pleased to hear. This is an unusual one, I think. It's come from a health and social care professional who said they're supporting a 68-year-old patient who was diagnosed with PSP approximately 8 years ago. So it's quite a long length that they've been living with this condition. And his wife has noticed what she describes as confusion. She sometimes understands him within this confusion, but what would this be expected to be? Would you expect this with a diagnosis of PSP with that longevity, or do you think it could be something else? Is it a purer dementia, do you think?
Gosh, that's a hard question to answer, I think, isn't it, without knowing more about the patient and kind of what's happening. So I'm sort of reluctant to give too definitive an answer of what I think is happening for that particular patient, just because I don't know enough. Maybe a few things I'd think about if I was asked this question, and where would I begin to maybe start teasing it out. Because I think the key thing there with this is, well, what do we mean by confusion? I suppose that can mean many different things. Is it disorientation? Is it evidence of more forgetfulness or recognising people? What might that be? And it could be all of those things or none of those things. So I think it's difficult to answer really too much in detail. And so I probably want to know more about what they meant by that, what that looks like, how it's presenting. I'd want to know if this represents a sudden change for that patient. And does it fluctuate? And if it does, what does that look like? So I think really, you know, if that's a concern someone has, I think trying to kind of take that to neurologist or their neuropsychologist, you know, what other profession may be available to start exploring that. There may be certain things, steps you might want to take, you know, in terms of going through what this might be. So I guess and should maybe thinking first of all, there's no medical explanation for confusion, particularly if this is new. So checking for things like a UTI or other infections could be a sensible step as well, which the GP can maybe help with. Make sure there's been no change in things like medications that coincide when confusions maybe started. That could be some practical things that could be looked at. I think in terms of that question of, you know, with PSP after 8 years, what could this be? You know, with conditions like PSP, especially after that time scale, then it wouldn't be unexpected for someone, you know, to present with significant cognitive impairment. Typically the main feature of cognitive impairment in PSP tends to be difficulties with executive functioning. And many patients may indeed go on to develop a dementia that has frontal temporal features. There may be some behavioural changes that may accompany this, as well as more widespread cognitive changes. But it's difficult to say or know if that's what's happening with this person without more information, but probably just using this as an opportunity to raise that cognitive difficulties are common within PSP. You know, we often see patients at different time points in their kind of journey where maybe we might think it's valuable to have completed a cognitive assessment to use a baseline should there be significant change or concern around cognition further down in their journey. And we can do a bit of a comparison, but that might not be always possible for somebody to have that, get that baseline. It may be that, you know, depending on how well someone is, could they engage in any cognitive assessment, it may not be possible at that point either. And sometimes, you know, we might get to a point where actually it's maybe not so much about naming or defining what this is, but it's more about responding to the symptoms and giving advice on the management of that. You know, is this quite distressing for the wife to see? Is it about supporting to help her manage those episodes of confusion when they arise? You know, making sure there's support in place for the patient and for the family. Sometimes that can be the more helpful focus rather than trying to define, is this dementia, is this just PSP cognitive impairment, is this what's it progressed into? That might not always be the most helpful question. Because if we can kind of, I guess, help families have some psychoeducation around the condition of PSP and help them understand cognitive changes or progression of the cognitive symptoms as you go through the journey, that can just be helpful, even just to help them understand what they're seeing, can take you some anxiety and fear there. And that might be where this patient or family are, but it's kind of hard to know really exactly how to answer that without no more information. But I guess it's a couple of things I'd be thinking of and maybe advising it being more about symptom management.
Excellent, thank you. No, I think that's really good. I think overriding for me through all these sort of questions and discussion points that we've had is the importance that it's very much, it's not just about the patient here, it's about the family and the people caring for them as well, and an education, and that's, I think that's really important that you've brought that forward in your answers, because I think often people don't get that opportunity to do that and to understand, and I think a lot of it is about understanding, isn't it, from the sounds of things? Absolutely.
And I think, you know, giving people information doesn't take away, you know, a lot of the difficulties and challenges are there, but I think if they feel a bit more equipped and informed, it does take a little bit of anxiety away, and they're making sense of what they're seeing and feeling a bit more equipped to manage different things that might come up. So and I think with the depression question, I think that's kind of, I think the point maybe I was kind of trying to make a little bit as well, is it doesn't need to be an intensive kind of higher level intervention that patients and family always need. That sometimes it's just information, sometimes it's just a conversation, sometimes just normalizing someone's experience and saying, yeah, that sounds really difficult, or that sounds hard. You're not alone in that. You know, we understand how you're feeling, or we're linking them into more social supports. That can sometimes be the most helpful thing you can do in that moment for that patient. And I think as professionals, sometimes we do feel pressure to always have the answer, and we don't always. And I think sometimes being confident to say, well, I don't know the answer to that, or actually recognising there's some things we can't change or fix for people, despite no matter how much we want to. So sometimes as professionals, kind of giving ourselves permission. So we'll do the best we can, and you know, we'll absolutely support people where we can, but we don't always have the answer. But all we can do is assess, support, link in with what we do have available, and hope that's helpful.
Excellent. No, I think it would be. I think it would be, and it's really great. So that's the end of our questions. You're pleased to hear. Thank you so much for joining us today.
Oh, it's a pleasure. Thank you.
Every day is a learning day, and I've learned more again. But no, I think there's some really good information there. It's great to have had this conversation with you, and never know, we'll do it again another time maybe.
So thank you very much. Thank you.